Afternoon. It is the 30th of July. I'm Matthew Holt, the host and publisher of the founder and publisher of THCB and the host of the THCB Gang. And I've been joined today, as you can hear in the background, by my dog, who's decided to break into my office and scream loudly. Now we are. I've got a great group today, with a bit of chaos interference at the start. Some last-minute guests from regular Ian Morrison, who's been awarded by my dog, the health futurist, former president of the Institute for the Future. Jess Damassa, my co-host at Health in 2.0 and host of WTF Health. Rajesh Aggarwal, all the way from Philadelphia. We're going to have the other British Philadelphia doc on today with Saurabh Jha, but he had to drop out the last minute. And then Kim Bellard, exec teacher. Meanwhile, well, that is loud in the background. And our special guest today, good friend of mine, who we've been trying to get on the show for a while, Jen Benz, communication lead at Segal Benz. Also, some of you are a big fan of my dog. All right, let's go live. And I'm going to have everyone start off. Well, I'm going to go and try to get rid of the dog. This is live broadcast.
He's our live puppy studio audience. I need
we have our live studio audience. He's whining like hell about how he got in here. Now I have to try and figure out how to break him out. But while I disappear for a second, let's go around the horn, starting with Raj and then Ian, about what you guys have seen in the last week. And I'm going to go mute and I'll do some professional dog catching. So the Raj, then Ian.
All right, cool. So I'm going to start with just some of the financing news. And I know Matt's been tweeting about this. So Withings raising $60 million, being reacquired from Nokia, and then, remote monitoring tools as a Series B. That's a lot of money for a Series B. I'd like that for a Series B. And then even better than that, Thrive, it's a free DNA company, raising $257 million for their Series B. That's just like crazy money in my mind. They previously raised just over 100, I think. And then just to put this in context, I don't know if you guys remember Proteus Digital Health. So that raised like 400 million, was valued at 1.5 billion. I think it's an amazing technology. And they're now in a stalking horse bid with Otsuka for 15 million. Kind of interesting news in a few days.
It all goes up and goes down, and I suspect when we get to Jess, we'll talk about a certain publicly traded telehealth company and what's going on there. Ian.
Well, I'm more sort of the sweeping generalization guy. The thing I was thrilled to hear was that the White House beefed up its science advisors to include experts on alien DNA and demon sperm, and I gotta say, it made ingesting bleach and shining light inside the body seem like sensible science. But the next step will be to bring in the entire editorial board of the National Enquirer as advisors. But brutal, absolutely brutal. The one positive piece this week, my native Scotland had one day earlier this week, only 4 new cases and 0 deaths. Which I thought paid testimony to the fact that they have been on severe lockdown almost until about last week. Black pudding sales is up like 40%. They're all having deep fried Mars bars, staying at home, drinking cheap beer, which will kill them in the long run, but in the short run, it's keeping them away from COVID. And I raised that by way of example that it's the contrast with what the Congress has got to do this week, which is do something about unemployment insurance or not, and live with the consequences of that. Because I think part of the story of why we're doing so badly is that we were all forced out through economic desperation compared to other countries. And I got a couple of other ones, but let's go around the horn and we can add some more if we've got time.
We'll drag them in. Jess.
All right. So, it's funny you bring up losing weight because I'm going to talk about Teladoc in a second, but CVS, as part of their beautifully named Point Solutions digital health formulary, added 5 new digital health solutions to the 6 or 7 they've already got in there. And 4 out of the 5 have to do with weight loss. So really interesting. Weight Watchers got added. Weight Watchers childhood obesity product, Curbo, got added, something called Naturally Slim. And then I think you can argue that Vita, which competes with Livongo in that space, it has kind of an obesity management component to it too. So that was interesting. So see where we're headed.
The bariatric surgeons out of business. That's what they do.
Oh yeah, let's just start right there. But the big news is those Teladoc numbers, which are like, this is the quarter everybody's been waiting to see, the Q2 numbers. So everything's, what you expected to tick up would tick up. So, right, they're saying that their number of visits hit 2.8 million, more than triple what they had last year. Their provider business directly into the health system increased tenfold. And that's kind of significant. There might be room to grow there because the deal with the company they acquired, InTouch, which does all that in healthcare system stuff, that only really finalized at the beginning of this month. So they've been working in like a sales partnership agreement up until this point, but and have rolled out together, but I think there's opportunity there to move up. What's still tough about this is despite the fact that they now have a $19 billion market cap, still not profitable. They missed again. And what's interesting about this is if you look at their loss now in this quarter, it's only about 4 million off from the loss that they had this time last year. So this year they're reporting a loss of about 25 million for the quarter. And last year it was 29 million. So not much different despite all the increase. So I don't know what this is all going to mean in the end. I want them to win, but it's like these numbers just, I don't know. Maybe I've been hanging out with the crabby old and British for too long, but I've become skeptical.
only 3 on the phone and that.
Yeah, I'm going to throw the lot of you underneath that double-decker red bus and just say that you're crushing my enthusiasm.
Curb your enthusiasm crowd. Kim, can you infuse us or not?
Well, first I hope that your dog is not one of those COVID sniffing dogs and he's trying to tell you something. So.
Probably, who knows?
But so in the midst of the pandemic, I want to talk briefly about the epidemic that we're seeing now. It's the epidemic of stupidity from Texas. And Ian touched upon this. First, we have the demon seed pediatrician who believes that masks and distancing don't work. Hydroxychloroquine does. And then we have Representative Louis Gomart, who doesn't believe in masks, got COVID, blames the masks on them, and is now, of course, taking hydroxychloroquine. So there's something going on in Texas that's well beyond just the pandemic.
Yeah, and apparently after he got it, he wanted to tell all of his staff in person because that's how he wanted to find out.
And apparently he was not allowing his staff to wear masks either. So,
oh my God,
it's all genius, right? So Jen, we'll dive into your world and the employer, your life in the employer world in a bit. But first up, just what have you noticed in the last week that's struck your fancy?
Well, connected to some of the things that others have talked about, there's just this absolute explosion with HR technology and the healthcare technology that's supporting large employers. These companies are getting huge increases in their stock price, tons and tons of attention. And I think that's really interesting how that's going to reshape the employment landscape. And then it has a bunch of connection points to driving engagement with digital health solutions, as well as solutions that impact retirement and all the other benefits and programs that are supported through employers. So I think that's been really interesting. Caregiving is coming up as a big topic, and we're seeing lots of headline stories about how that's going to be a key to whether or not we can open the economy and whether we can really get people back to work. And that's certainly a huge topic to dig into. And then I wouldn't say that Texas has the corner on people being dumb. There's plenty of articles going around about folks in California where I am still hosting large gatherings and so forth, despite any sort of common sense stating otherwise.
Well, we were going to talk, if Saurabh had been on, about Johnny Nardis, the Stanford professor who is either saying that we shouldn't be locked down or not, depending on how he believes. There's actually an interesting interview with him on the healthcare blog that Saurabh did a couple of weeks back, and there was a sort of a bunch of exposés about how he was trying to influence Trump with a bunch of other folks that Stephanie Lee wrote on BuzzFeed, which maybe we'll get into that later, or maybe we'll wait till next week. But interesting sort of think about the philosophy of, should we be locking down, should we not be locking down? Who believes in? There are a bunch of smart public health docs, including Jeff Klausner, I was on the board with at one point, who say we shouldn't have locked it down. And, people are rewriting history already. It's still happened in that March period. My take for the week, I'm just going to stick with, the good old PPP program. ProPublica exposed about 4 or 5 nursing homes, which somehow, instead of being one big nursing home chain running 30 to 40 nursing homes, were in fact 30 or 40 different LLCs, each of which managed to get their PPP allocation, and one of them got a total of 97 million, which is rather more than you're supposed to take. The maximum for any one company was supposed to be 20 million. I'm still waiting to sort of, as Ian says, we're waiting for the next sort of stimulus expansion, whatever rescue package that's coming out, if something comes out this week. But it's clear there's plenty of weird stuff going on in the last package, and it was just really remarkable that when ProPublica went and found the companies that really put their hand in the cookie jar, almost all of them were healthcare related. I guess we shouldn't be surprised. Fraud and deviance in healthcare is a big trend, but nonetheless.
There's something we're good at in healthcare. It's paperwork.
Paperwork, fraudulent paperwork applications.
Paperwork that gets you paid, we got a lock on that.
Look,
Let us fax you a copy.
We're still, but we're always talking about how do we change the payment system value. We're still basically in an environment where if you can get yourself a provider number, you can start billing away, and maybe somebody will stop you, but maybe not. We've had a lot of instances of that over the last few years. I know Kim's written about that a fair amount. All right, so let's dive in. Jen, you're our guest. Thanks for coming on. These days you are I want to say you're the senior VP at Segal Benz, but when I met you, you were running Benz Communications. And your specialty is helping employers tell their employees about their health benefits and what they should and shouldn't be doing. And I met Jen about, a decade or so ago when she was giving a talk at Kaiser about digital health, and knew far more about it than I did, and I just felt embarrassed as the keynote speaker. So tell us a little bit about, what you do briefly. And then you mentioned some of this issues around sort of HR systems. But I guess what I'd love to get into pretty soon, and Ian's written about this a bit, is how much are employers thinking of changing what they're doing in terms of delivering healthcare benefits, paying for healthcare, and all the rest of that. So start off, just tell us a little bit about what you do, and then what you know.
Yeah, so I have spent my whole career, so 20 years in the world of employee benefits and employer-sponsored healthcare. I run a communications group. We're part of Segal, which is an HR consulting firm. And we work with a really interesting group of organizations. We work with big public sector employers, big cities and states on their health and pension systems. We work with big corporations. We have a lot of high-tech clients and a lot of financial services and other kind of 100 best companies to work for, organizations that we support. And then we also work with a segment that's really interesting, which are the multi-employer health funds and multi-employer pension funds. And so those are organizations that where the unions and the employers are part of making decisions and administering health benefits for folks. And so lots of complicated organizations in the mix there. And we touch all aspects of healthcare benefits, and then all aspects of retirement and work-life benefits, kind of all of these programs that are administered and offered through employers, because our country doesn't have the safety nets that would make sense for a developed nation such as ours. So it's really interesting work, and particularly this year has been really fascinating.
So tell us a little bit about what employers that you're talking with, and where are they in terms of what programs they're interested in, what they're trying to do, and then how much has this changed? Because you got to assume that the previous 4 or 5 years, people have been layering on new stuff to try to attract employees and compete with others, in a basically a full employment economy. And all of a sudden, March changes everything, and now things are going to be different. Yeah. So what's the conversation now amongst the clients you work with?
Yeah. Well, the last several years have been kind of an arms race of employee benefits, particularly with high tech and the other industries that have had to really, really compete for talent. We see companies just layering on more and more benefits and perks, and really, really high touch healthcare benefits, all sorts of well-being programs and mental health programs, and then lots of things like paying for student loans and lavish on-site perks, and all of the things that Silicon Valley companies get made fun of. And that's been kind of one end of the economy the last several years, like the industries that have really been growing and really having to compete for talent. But that wasn't the case across the board. Many organizations the last several years pre-COVID were struggling with providing good quality, affordable health benefits. And there's a lot of innovation in the market because of that. We see things like with centers of excellence and very high touch advocacy models and direct contracting and so forth to try to really control the costs and the outcomes for healthcare. So there's a lot of innovation in the employer market, which makes it really interesting. But that has shifted in a lot of ways. This year is a lot about trying to get people to engage with and access the programs that are going to support them through this crazy time. So we've seen a big focus on trying to get people to engage with telemedicine, and of course, a huge spike in it, and then those numbers are gonna fall off as people kind of go back to old habits. Lots and lots of energy around trying to get people to the right mental health resources, and then the right support for managing their families, and whether it's caregiving or trying to manage kids at home and so forth. And there's actually been most recently, even in just the last 4 weeks or so, there's a lot of new players trying to help with parents who are going to have kids at home for the fall. And how do you actually work and have young kids under your feet and so forth. So that's been a lot of what we've seen so far this year.
Dog care, is that coming up? Just only kidding, because about this program started.
Pet insurance is more popular than you would imagine, actually.
There's a new.
But I can't get anyone to pick up the dog.
There's a second telehealth company for veterinary care that just got money today.
Oh yes, what was it called?
Oh, wow.
Or something like that. Something with the word dig in it, I think.
Mm-hmm.
And we had one a couple of weeks ago called Dog, and we started calling it Dog
Dogsimity. It's not what it's called though, but we started calling it that. Teledog.
Online teledog.
Dogs not the man.
But so,
Can I ask a question?
Yeah, go on.
Jen, I'm listening to you say all this stuff, and like the things that employers are worried about, are they questioning why they're also worried about healthcare now? Are they starting to ask themselves like why? Like the same way they're asking themselves about office space these days? Like, okay, well, why don't we just have everybody work from home? Are they also having the rhetorical moment of like, why are we in charge of providing healthcare to all of these people?
I've been having that rhetorical moment.
Well, yeah.
I'm not sure about the employers. It's actually a really interesting question because, I love the employer-sponsored healthcare space. There's a ton of interesting innovation, and employers are, in many cases, are very good at managing health benefits and improving outcomes and all of these things. But why do they do that? That's kind of an accident of our history. It's not necessarily the best way to set up a system like this. And what I also think is really top of mind right now is why, when you lose employment, are there so few options for good healthcare, good affordable healthcare, even with the ACA, mostly kind of still intact. So, and that's been a huge topic of, when folks are furloughed or when they go from full-time status to part-time status, when people just stop working and there's no more money for their health benefits, the options are not great. COBRA is outrageously expensive. The options on the exchange are super, super expensive, and it's super hard for people to navigate. So we've seen this huge drop in health insurance coverage with that drop of employment. And I think that's the big thing that employers are really focusing their attention on right now is, why don't we have better options for when people lose employment?
So, Jen, I have a question. So I'm a bariatric surgeon, and I've been following what Walmart and Cerner and others have done in terms of centers of excellence, right? So I think I'm a pretty good bariatric surgeon, but Jefferson Bariatrics is not a center for excellence of Walmart. Anyway, we'll figure that out. But outside of the perks of having, nice coffee and all of that kind of stuff, the Silicon Valley stuff, this to me seems like something real and something that's really driving the market. And I'd love to get your take in terms of centers of excellence and how that happens and what the outcomes are of that. And then what I'm really interested in, the leverage that someone like Walmart would have to, say, Geisinger or Cleveland Clinic when they are deciding on that center of excellence approach as a health system. So that's number one. And if I can have a second one, which is, so I don't know about this space very much, but is Accolade, you know, they recently IPO'd, is this kind of in this space? And when you said that you advise employers on how to, for their employees to get the best out of their benefits, that's what I understand, the squeeze that Accolade does as well. So I'd love to hear about your thoughts on Accolade as a company and their future as well. So those are my two.
Yeah, great. I would love to talk on both of those. So I'm a big fan of centers of excellence. And I think that this is a really, really smart model for healthcare in general. And, you know, the philosophy there is that an employer or a health plan sponsor can say, you know, we know that we have these types of high cost conditions in our population, and we're going to get the best providers to support our people, even if that means they have to travel. And then we're going to contract directly with them, and we're going to negotiate a price. And if something happens after the surgery where someone has to go back to the hospital, the provider's on the hook for it. We're not going to pay more for that. So this is really good in a lot of ways. And I should say, in full transparency, I'm an advisor for Carum, who is a company that I think has created a very, very good solution for this. And they sell to large employers, including large public systems.
Jen, does Carum have Jefferson in its network for bariatric surgery? Because you might get pitched now.
I mean, I'm gonna call them right after this and make sure. But the question here, and I think the reason that large employers are really focusing on this is, why do we let people go to poorly performing providers? You know, we know that there are really great outcomes in some places and really bad outcomes in others. So why do we let people choose wherever they want to go based on whim and, you know, in general, not really having that much data or education on it? So I think the COE model is really powerful, and employers can really move the market on things like that, and can set set expectations and negotiate very, very well on cost. It can be something that saves a lot of money.
These delivered, Jennifer, these partnerships. So you're saying, you know, Cleveland Clinic is better at heart surgery and Geisinger is better at weight loss surgery and so forth. Have the outcomes been published or made public to show that delivery? That I would not. I can't say I've looked at the data recently on that, but that is certainly the promise, is that we're choosing providers that have better outcomes to start with, and then we're going to continue to watch those outcomes and ensure that they meet, that they're satisfactory going forward.
Jen, do you know anything about what's the data on, do employees believe that their employers are actually choosing it based on outcomes as opposed to getting better price deals? Because employees have always been very skeptical of the providers that they're steering them to.
Yeah, I mean, it goes back so much to company culture, and this is the challenge with employer-sponsored benefits. You can really influence people a ton if they believe in you and if they trust in you. And there's a lot of research out there that shows that employers are a trusted source of health data. And we've seen that, especially with some of the high-tech companies we've worked with, where they're really able to drive outstanding engagement rates with their health programs because people trust them and they believe that they're doing it in their own best interest. But there's plenty of skepticism too. And so there's a lot of communication and education that has to go with it. And that's why the most successful COE programs have not really focused on the outcomes or the cost savings, but focused on the experience. So they wrap them around with a concierge and this very, very high touch experience, so that me, the patient, I feel like I'm really being taken care of and that my needs are first and foremost. And those are the ones that have been most successful.
Jen,
and that kind of,
go on. Sorry.
I was going to say that kind of touches to Accolade too, and create a more high touch healthcare experience. But go ahead, Matthew.
Well, I mean, I was going to say for Accolade, and you've got a bunch of others who are kind of in this space as well. That'll be Grand Rounds, I think, or others who are trying to look at those high cost cases for employers and change what actually happens, right? And now you've got relatively recently, Hinge Health got $90 million of around, and they've just expanded, and they're in the back pain space, which is where I can see is where almost all the savings in this stuff comes from. If you can stop people having back surgery and get them into physical therapy, and they're just as happy at a much lower cost, that seems to be where a lot of the savings for all of these navigation programs come from. It seems to me that group as a whole, I mean, has got a sort of big opportunity. But on the other hand, well, actually, I'll let you comment. How do you think they're doing so far? Because Accolade's got public. It looks all right. It's making, it's losing some money, but not as much as some other people that just mentioned.
Yeah, I know the Accolade team well, and I think they have a really, really great product, and they do a very good job creating that high touch healthcare experience and giving someone a resource to help them navigate the system. And I think this is one of the things that there's been this kind of false promise of consumerism in healthcare. Oh, we're gonna teach the average person to be a good consumer of their healthcare, and we're gonna put them in high deductible health plans so that they need to, have some skin in the game with their healthcare, and by doing that, they're gonna transform the system. Well, no, they're not, because it's impossible for the average person to become an informed enough healthcare consumer to really navigate through all of the complexity. And so you have services like Accolade that really take that responsibility off of the individual and help script their moves and help them know really what they can do. And there's a lot of opportunity to get people into less intrusive paths, whether it's physical therapy instead of surgery, or seeking different types of care. And when you do that wrapped around a really high touch experience where people feel like their personal needs are being met, I think there's a lot of potential there.
So I would dig in. I want to get us back to your bigger point, and I want to drag you into this in a minute. But the big question is, if you look at Accolade, they've got 50 odd customers, and Comcast is by far the biggest, right? So they're making most of their money off Comcast. But they don't, they have 50 customers, not 500. And then even when you look at some of the players, and not quite in the same space, but the Livongos who have got several hundred customers, they don't have that big an uptake within. This is back to the sort of job you do at Segal Benz. They don't have that big an uptake. I mean, if you look at Livongo, it's like a third of the people who could be in their programs who have diabetes are in the programs. Where are the other 60, 70%? And I'm always sort of wondering about, I was just on a site which I'd never heard of, a company called Redl, which was in this sort of wellness space, and they were talking about how they were boosting people to do boosting engagement in wellness programs and boosting engagement in screening. And Al Lewis, if he was here, would tell us that that's the stuff that actually is a complete waste of money and we shouldn't bother. So I'm kind of wondering, how impactful can these sort of third parties coming in helping employees to do this thing be, versus a much more draconian approach, which most employers haven't taken yet and maybe will. So they can be really impactful, but it takes a big effort to get people to actually use the programs and to stay in them. And that's one of the biggest mistakes that digital health companies make, is they see employers as like, oh my gosh, this is awesome, we're going to sell to this 50,000 person company, and then we're going to have 50,000 new users. Well, no, you're going to sell to the 50,000 person company. Then you have to get on the communications timeline. You have to, maybe get that email. Like, you're lucky if you get one email out to the whole employee population. You're lucky if the employer actually even has emails for all 50,000 people. So there are a lot of barriers to just getting information out there. And this is why I have a job, because it's complicated to get. It's complicated to get people to pay attention to all these programs, but the companies that do it well and really invest resources in driving engagement, they can get good outcomes and they can really get good results. But it takes a big effort, and it's a piece of the puzzle that digital health companies oftentimes ignore. And I can't tell you how many founders I've sat down with where I say, well, how are you going to drive adoption of your program? And they say, well,
the employer is just going to send an email out and everyone is going to sign up. And that doesn't work that way.
Well, can I push back on that from a clinical perspective? So if you take Livongo with diabetes, right? And so in any kind of chronic disease, you've got three groups of patients. You've got patients who are just doing fine, and whatever you do, you can't make them better because they're just doing fine. You've got patients who are doing badly, and whatever you do, you can't make them better because they're just going to carry on doing badly for whatever reasons, right? And then you've got that middle group where you can actually move the needle. And that's where Livongo is focusing on. So if it's 37% of the employees that are signing up, the thing that's really interesting about Livongo, and I don't know the data for other digital health companies, but 96% of their members that sign on then keep signing on year after year, right? So that's really strong. So now you've really got that group that you can impact on. So I don't think it's like if Livongo had 80% of their employees on board as members, but only 40% were then repeat signers, then that's, I think that's failure. I think you got to focus on which part of the market, and it's not everyone who's diabetic.
We're about to see the Livongo stock price tank because Raj has just announced that they have no more same-store growth left.
Stop it.
And everything they were telling telling Wall Street analysts is now what?
I want to ask a quick question here. How does health equity figure into this? Because, I mean, I feel like when you talk about employees, it's like this massive employees, assuming that they're all the same. But if you're working at Amazon and you're working on a dock or in like one of their packing facilities, you're living a very different existence than corporate Amazon here in Silicon Valley with the fancy coffee and the catered lunches. So, I mean, you might have, a lot of times they have different, health plans, different programs for different price levels, right? So, I mean, how has the health equity side of this entered into the conversation, especially recently in terms of, maybe not so much affordability, but just access and people's lifestyle and those social determinants kinds of things. Like, maybe if you have a white collar job, it's much easier to sign on to something or, to check your CGM all the time. But if you're, running around back and forth, it's a lot harder for you to want to go and work out at the end of the day after you've been on your feet for 14 hours. Putting groceries across a conveyor belt at Walmart. So how's that been coming up lately, especially because it's so hot right now in terms of a lot of the other things that are happening?
Yeah, I think it's such an important topic, and employers do think about that a lot, but I don't know that they always fully understand the social determinants or just how much income plays into ability to take advantage of all these programs. So one thing on kind of the nuts and bolts of affordability that many companies do is they actually have higher paid employees pay more for healthcare than the lower paid folks. And I think that's a really great approach. I think it fits with corporate social responsibility. And when we have rolled out new rate structures like that, in general, the company gets really good feedback on them because you want to be taking care of the folks that are lowest paid. But your lower paid folks might be working two jobs. They might, they might have all of these other challenges in their life. Yeah, and do they have a smartphone that can download the latest version of whatever digital health app you want them to use? And there's so many barriers there. I think it's a big challenge, and I think it's something that employers have a unique position to really impact. And there's a lot of effort that goes into understanding affordability and access in different regions around the country and so forth. And I think what's going to be fascinating is how the racial disparities in healthcare conversation evolves. And one thing we've been talking a lot about internally at Segal is can we do more analysis on the racial and socioeconomic disparities in a population? And is your benefits design really helping impact some of those things that people show up with on their first day at work? And how can employers really be a driving force in helping correct some of those disparities?
Big topic. I want to helicopter up to some other big topics. So Ian, I want to drag you in because when I met you in 1992, you told me that employers in healthcare were cranky, confused, aimless, and spineless.
Correct.
I don't know if your opinion has changed much, but if you were to look at the big picture, employers have paid more and more for healthcare and haven't really stopped. And the ones who can't afford it, who have mostly low-wage employees, have kind of got out of offering healthcare. which results in, and then when you have layoffs and then recession, you like Jen's earlier point, which is, we have Cobra, which I did notice that the only thing that seemed to change in the current Biden-Bernie Democratic plan for healthcare, which was sort of announced last week, well, not quietly last week, they haven't been saying much, was that Cobra was going to be covered, and that was their solution to this problem. Strikes me that's not a great long-term solution to it. So where do you think we are?
Yeah, well, let me just speak. First of all, I think I agree with almost everything Jen said, and that my basis, Jen, is not sort of direct working with individual companies, but I've been an advisor to the Pacific Business Group on health for 20 odd years. So, and in fact, was in their latest board retreat speaking and listening in. And I think it supports almost everything you said. But Matthew's right. Back in the day, I described them as cranky, confused, aimless, and spineless. And they're partly to blame for the problem that they have. The entire margin of the health system is derived from private employers, right? And, overpayment by private employers relative to Medicare and Medicaid. And they've never really used their muscle effectively, in my view. But the trends you describe, I think, are all there. And certainly the power, if they act in concert, and that's what they've been unable to do, in my view, is there to really shift the market. I do think you're right. The Centers of Excellence is one vehicle that certainly PBGH has pioneered and is willing to amplify. And Raj, to get to your point, but I actually had this group of my Valkyrie friends. I called them the Sally Wellborn, who ran benefits for Walmart, and Barb Waxman, who did it at Disney, and Ann Boynton, who ran CalPERS at the time. And I used to go from meeting to meeting and unleash them, I mean, literally, on hospital CEOs to scare the hell out of them, because they would talk about what they were doing with Centers of Excellence and so forth. It turns out that, and I've never actually seen a scientific study of this, but this is the reports from the people doing it, is that the reason they saved money was not because they negotiated a better price per se. They negotiated quality and terms of conditions, and in most cases, a screen for appropriateness, right? And that was what paid off, because what they found was between 20% of cases and 50% of cases were deemed inappropriate. It was about 20% in the case of hips and knees, and about 50% in back pain surgery for low back pain. And I think that appropriateness screen is a really important issue. But you raised something earlier that I think is terribly important. Their Achilles heel is they confuse choice with quality, right? And they imagine that their employees want more choice than they really want, right? Matthew and I did these surveys. We've been doing them for 30 years of employers and consumers and so forth. And employers think that employees want more choice than they really want. They'd rather have something cheaper,
Yeah.
right?
Absolutely.
And
I'm not sure I
the
agree
challenge,
with that.
sorry,
Look
the
at what's
challenge
happened
in
with-
communication is huge. Sorry, Kim.
15 years ago, narrow networks were all the rage, and it got beat out because that was not a winner in the marketplace. I mean, the employers are the ones that go for the low cost health plans. The employees do not like it.
Right. No, there's
Mhm.
pushback. They don't like it. Yeah. Because it
also,
doesn't
yeah.
include their providers. That's the thing.
Yeah. They want
Mhm.
their doctor. They don't want to go to some doctor. I mean, Centers of Excellence have been around on the carrier side for well over 25 years. Almost every carrier has them. And yet I don't think they're making a dent in how many people are using them. It's not changing the patterns of where people are going for the most part.
Yeah, we were looking at that data with one of our clients just last week, and they said, we have this preferred network within the network. How come no one's using it? Well, no one's using it because you haven't put enough money on the line, and because their provider isn't in the network. But I think that's one of the biggest opportunities in healthcare, and I think it's one of the biggest opportunities with employer-sponsored healthcare, is to change this notion that more choice is better in healthcare. That I should have the choice of any provider out there. I don't want to go to any provider out there. I want to go to the best providers out there. But no one has done a great job of really changing that dynamic of pushing people to just the best ones. And I do think employers are overly sensitive one of the number one things that they want people to know when they switch carriers is that 99.8% of those providers that you used to have in your network are still in the new network.
See,
Well,
I
we should question why.
people don't want the best provider. In most cases, I don't think people want the best. In most cases, most people want the most convenient provider, because unless you have a life condition, they're all the same. Most consumers do not create quality between different providers.
Well, it's also what means best to me as a surgeon means best as a health system CEO means something different to the CEO of Walmart, means something different to the packer in Walmart, means something different as well. And I think that's what you're getting at, Kim, here is, what is the best hotel that you've been to? It means something different to all six of us, right?
Yeah, I have a minority opinion about, this whole thing about people can't be good healthcare consumers. I would say that's true, but it's not the problem. The problem is we're terrible consumers generally. We fall for fall for advertising. We fall for consumer very important endorsements, and we fall for cheap prices. The fact is, in healthcare, we happen to notice the adverse outcomes of that more than when we buy the wrong shoes, or the wrong cars, or whatever. It's not. It's not a unique problem. It's a pervasive problem. We just happen to notice the outcomes of bad decisions better.
I don't know. I think there's also.
I think that's a great.
Go on, Jen.
Go ahead, Matthew.
Right. I was just going to say there's also, in general, less understanding of what a good outcome is. I mean, it's quite hard to buy a bad new car in America. They're in general pretty good. And they get a lot better. And they're going to change dramatically with electric cars. But I mean, it's quite easy to buy poor healthcare. And if you really stretch across the healthcare system, if you look at, some of the areas that are really come under threat under COVID, such as nursing homes and home care, you can buy some really bad healthcare out there, and we have done collectively. And I think that there is a sort of consumer solutions as well. The other thing which I was going to raise is that I think this has changed over the last years. It used to be that people would say, well, I want my doctor in the network. But a lot of people don't have doctors now. We have all these urgent care centers and, when you go on a teledoc or you go to urgent care or whatever, you don't have a relationship with the doctor. I remember talking about Walmart, Marcus Osborne was at Health 2.0 a few years back, and he said that they surveyed consumers and said, how many of them have a regular doctor? And about 30% of people said they didn't have one. Then for of the 60, 65% who said they did have one, they asked the doctor's name, and half of those people didn't know the name. So I think this relationship between the doctor and the primary care, the Marcus Welby type, has gone away. And to some extent, what I think the thing that you didn't mention at the start, Raj, but was the huge numbers this week also going to things like Heal, Walmart doing a deal, Walgreens doing a deal with Village ND, Walmart building its own centers, Humana putting money into Oak Street and Heal and others. To my mind, indicate that you've got a really interesting, sense of, can you grow kind of a brand of healthcare provider that is not necessarily an individual doctor or somebody that you have a personal relationship with, but I would actually trust that, Jess will laugh because I've been on the phone with every bank in America this week for various reasons.
And you're here.
Can you get one that is better? Sorry.
Take that blood pressure.
I want to know what you're doing in Brazil with all this money.
Yeah,
I really want to know what the deal going on in Brazil.
I've now laundered $750,000 to Brazil. Don't ask why. Don't ask why Kodak stock went up.
I don't want to know.
Nothing. Don't want to know. But I tell you, it's very hard. Whereas, and that's actually a fantastic example. If you want to do a wire transfer to Brazil,
oh my God.
If you want to do a wire transfer somewhere else and can use TransferWise, it's very easy. If you could give me the equivalent thing in healthcare, this brand makes that transaction easy and nice and good for you and takes care of it. That's great. And maybe that's where the Heals and the Village MDs now are trying to develop. I mean, I don't know if it's a fair cop. Whereas, the traditional healthcare system, quote unquote, has sort of failed that. And I don't know if we're seeing that grow with all this new investment or it's just another, flash in the pan.
mean, are we calling into question the romantic relationship that people have put on to like, I mean, I think we've romanticized the relationship between patient and doctor. Like, oh, my doctor, like, yes. I don't have that. I mean, and I don't really feel like my parents have that either. My grandmother does, but I think a couple generations now, not so much. Like, I'm like, let's teledoc somebody right now and see who we get. But, you know, I think that's been romanticized. And I also think that the way that people have maybe romanticized the employer-employee relationship. My father worked someplace for 25 years. I've never worked in one place for more than 4. So, I mean, I feel like that kind of has shifted as well. Like, you're not in the same job the same way you were when this kind of healthcare system was invented to pay for this, where it was like a recruitment tool for people after the war, and you lived through the 50s and 60s. I mean, things are different. So I don't know if that's
society,
like,
though. My dad used to go to the bank manager, and he knew him personally, and they used to play golf together. You know, my dad used to go to the same person to book the annual family holiday at the travel agent. That's just society. That's
but why are we doing healthcare like that? Well, so that's the thing I don't understand.
Has to hang behind everything else, right?
Yeah, Matthew's being cavalier with his wire transfer choices and his offshore bank account. So clearly that's changed too. But why do we romanticize the employer-employee relationship and the patient-doctor? I don't understand.
Great.
I mean, Raj, what percentage of hospital admissions come through the ER?
30%, man.
Oh, I don't know, but I do know a significant percentage. I think it's 20 plus. Don't quote me on this, but of our admissions into Jefferson come from transfers. Let's put it that way, right? And I don't know.
That sounds like a right number of high 20s, low 30s. For most hospitals, some hospitals it's lower than that, but
I would have thought it was higher than that, because, you know, as Jess was saying, most people are not going through their doctor to get admitted to the hospital. They're showing up at the ER and getting admitted that way, and so that goes against the face of, you know, having these preferred hospitals, because they're not going to drive an extra 20 miles to go to a preferred hospital when the ER is right down the street. They're going to go there, and they get admitted.
Right.
Or they're just getting.
But I think Jess has sort of highlighted the fact that you've got to think about these in slices of behavior, right? That the retail world, and it's the question I want to come back to, Jen, because the trend I'm seeing, and I'm sort of challenging, is more and more point solutions being developed by employers, layering on Livongos, on Omadas, on what all these things you guys follow and track. And I worry greatly that the sum of these point solutions is actually more expensive than the old model, right? Because of the you know, the management of all of that seems to be potentially hazardous. How the hell is that cheaper than just simply encouraging more people to go to Kaiser, or using benefit design more intelligently to select to these narrow networks? And so that's kind of a question for the floor. Do we see the future being the sum of the point solutions, or is this going to bite us in the bum in the longer run?
Well, surprisingly enough, I've written a piece about this and you can talk about it. I think the problem is, until you've got to blow up 2 things, right? One is the institutions, and I don't know if Raj, you and Steve Klasko. Actually, by the way, plug, Steve is your boss, Raj. Steve's written a new book, and we're going to have him and Amant Taneja on the health. God, sorry, did I say that word? Sorry. the new healthcare blog book club, which me and Jess are going to run starting next week.
Very fun.
Well, we're going to have a book club. So anybody wants to quickly write a new book, in about time you wrote one, Kim, we'll get you on. We've got the first couple lined up, but the first one's anyway.
Oprah, Matthew Holt is the new Oprah of healthcare with the book club now.
Going to be rich, famous, and run for president. It's going to be fine.
That's kind of.
But you could argue that some organizations, maybe Jefferson, are going to get there. But I've always argued that the current incumbents just can't get there because structurally, institutionally, they're not based with that. So that's one problem. And then I've been saying, well, you've got to build this thing that Jess named for me, the continuous clinic, because you didn't know my term PLICIMO, which is the patient location independent care integration management organization. But basically what I've been saying is
it slips off the tongue.
It slips off the tongue. I mean, PLICIMO is great, but I mean, basically what it's saying is that whoever you've got to look after them where they are, and you don't necessarily have to but that's a cultural change. Obviously, it's an organizational change, a cultural change, and a change in patient care. And those things don't really exist at the moment. But eventually, if you look at what all those point solutions are coming to, if you look at the Longo Spastimata, Longo bought a thing called Retrofit, which is kind of like it's a Marta thing, which Raj and I were going back and forth on weight loss. Back to Jess's point on Twitter earlier, and does it really work, and how long does it work for, and all that stuff. But there are the mental health stuff, and then the back pain stuff. And by the time you get all these different solutions together, at some point, someone's got to take command of the patients, especially the expensive ones who've got multiple chronic comorbidities, or these days have got something really bad and acute, but could be managed off-site. I know, Raj, you've been doing a bit of that at Jefferson, and I saw that the folks at Atrium in the Carolinas have been doing a lot of at-home stuff. They've been Russell Schuster and his colleagues there have been talking about it. Really, what we haven't done, though, is figured out how to sort of build a structure that can manage all that stuff together, because there isn't really, maybe it's Luongo, maybe it's Walmart, maybe who the hell knows. And then the line thing, which we're all screwed with, is we haven't figured out and haven't even got a policy proposal about how to pay for it. The only one I've seen is George Halverson saying put everyone in the country in Medicare Advantage and basically have them pay primary care docs or whomever, or on a regular capitated basis. But as Jen said, we've got how many million people now are trying to figure out where their health insurance is coming from because they can't afford COBRA because they're unemployed. And the best that Biden and Sanders can come up with between them on that solution for the Democratic platform is to come up with, well, we'll pay for COBRA for a while longer. or we'll reduce Medicare to people who are only 60. 3 more years and I can get there.
Right.
I'm at the point where I don't, I'll shut up, but we don't have, the bigness of thought, the big think that we need, given the point we're in. So I don't know, maybe somebody else is saying it. I'm not seeing it. I'm sort of frustrated.
Yeah, and I agree with all of that. And I would just add that a lot of these point solutions have come up to fill in gaps where the providers are not available, or where people haven't had a great experience with them and so forth. And I think a great example of that is on mental health. It's really, really hard to find mental health care providers, and a ton of digital solutions have come up in that, which are much, much needed. Will those eventually be taken over by bigger players in healthcare? Perhaps. But the question too would be, are the early adopters going to trust the big, huge health plans with some of those, new forms of mental health care? And so I think we have kind of an access and a trust challenge when it comes to solving for things that the traditional healthcare system has not done very, very well.
That's a great point, because the mental health demand, the data that Jess and I did in that talk showed that what mental health, anxiety and depression fundamentally have gone from 10, 15% to 30%. I saw some data from somebody else, I forget who it was recently, that 50 to 60% of Americans are currently showing signs of depression or anxiety.
It's my interview with Vita
Health.
It was the number they reported.
Sorry, who was it who reported that? Jess?
Vita Health.
Vita, right. Whatever the numbers are there, that's an area where clearly, the current system, which is basically cash pay for rich Marin County daddies paying for expensive art lessons for their daughters. Should I discuss my family? That's probably a HIPAA violation, but anyway, that's what it felt like. Is not really hitting the spot. And then but don't forget the other half of this, and Jess and I talked about this in the lecture we gave for the mental health conferences. You got some really severely ill people who are sitting on the street in San Francisco or New York or wherever they are, who are again who are costing a lot of money and not getting the care they need. Right. I always go back to, can we figure out a system that would, I think Ian said a couple of weeks back, fund the right parts of society in the right way to actually attract those solutions. And you've seen some venture money go there, right? CityBlock has just raised more money, and they're kind of a primary care clinic looking for the disadvantage. And you've got a raft of sort of upscale, downscale, and mid-scale primary care and mental health type companies being funded. You've also got a whole raft of sort of new types of pharmacy doing direct delivery of pharmacy, including the guys who will sell you your baldness pill and your male enhancement pill over the phone. Road, they got $200 million just this week.
1.5 billion valuation.
and apparently doing $250 million in revenue. Although someone did,
Just like Teladoc, no.
or someone did note to me, says you're spending $150 million in advertising, you probably should be doing a couple $100 million in revenue. You're not getting it right. But we don't have that comprehensive view of how do you manage all these different problems. And I think, as you said, Jen, the reason we have a job is we're layering on employers, and the reason we have a profitable healthcare system, as Ian says, is because we're charging the employers way more than the government's paying them.
Well, how can you be comprehensive when there's no, like, everything resets after a year? Your deductible resets after a year. You're in a new health plan. The benefit design resets after a year. Your provider could be in or out. I mean, so it's like, it's weird because the system, the way it's built is to, like, as much as, to Ian's point, those point solutions, you layer enough of those, it becomes more expensive, but we're built for that. I mean, everything resets after a year. There's no continuity. I mean, in the broadest definition of continuity of care, there's no continuity really from year to year.
Yeah, just on that. I mean, I think the big question is whether COVID causes us to re-ask the question that you raised earlier, which is, it's a really goofy idea and a historical accident, as Jen said, that we have an employer-sponsored coverage system. I mean, it's like, who came up with that? I mean, it's the dumbest thing going, especially when the amount of churn. I mean, in a small group market, about 30% of people turn over. I mean, because small businesses are very dynamic. It's true of large businesses. Covered California turns over 40%. So, to make investments longitudinally, unless you're Kaiser, who own people through retirement, there's no incentive to do that. That's why I think we're seeing this sort of, breakdown. And by the way, the COVID thing, we haven't seen anything yet, right? That because most of these big employers, the Marriotts, the Disneys, have been paying the health benefits for those folk through this. The unemployment rate is about to get the reality check, and then throwing massive numbers of people into the COBRA world. I think you're going to see huge pushback, and a big deal in the election is going to be finding something beyond the sort of tepid proposals that Matthew laid out. I don't mean you are tepid, but Biden's tepid.
I am king of tepid proposals.
Yeah, in terms of, I mean, I don't think you can pass much more than that, but we should be proposing some kind of safety net for people who move in and out of work and in and out of multiple employment situations, particularly over the next year.
Well, and I think that the signal event in our little world that everyone was saying, oh, it's going to be okay by the fall, and then it's going to be okay by next year. So the biggest conference in our space, which was HIMSS, 45,000 people showing up in Vegas, canceled in Orlando last year, was going to be in late February in Vegas. They've just pushed that back to August in Vegas, a nice, cool, breezy time to be in Southern Nevada, and if you look at this, the issues we're having just with baseball and who knows what else, we don't know. We have, back to the thing that Kim's been raising for ages, and you were talking about in sort of craziness in Texas and elsewhere. We seem to have no national idea. We're not New Zealand. We're not Norway. We seem to have no national idea about how to get this thing under control. And it's going to just keep impacting everything. And then we're all back to the healthcare system. All right, we are pushing ourselves on time. We're going to go and do our usual how we get out of here. It's been a great discussion. I noticed that we've been haranguing Jen a lot more than we normally harangue our guests. So both thank you and apologies, Jen. But I think the employer space is one that completely fascinates everyone just because of their role in the health economy. So let's real quick, what are we expecting to see in the next couple of weeks? I'll start with you, Raj.
It's a tough one. I think we're all on tenterhooks and seeing what's going to happen with all the COVID cases. Are they going to continue to rise? And certainly we're fortunate in Greater Philadelphia, they continue to stay flat. But I think that's really what I'm thinking about right now. And then focused on September, school's going to open.
Is dog school going to open, let alone regular school, in my guess? Jess, what are you expecting next couple of weeks?
Livongo earnings is next week. So there's going to be a lot of comparisons between what they're seeing and what we just saw come out of Teladoc. And I also expect that soon we're going to see birthday cake come out for Mr. Holt and also Kim, whose birthday is Monday. So happy birthday, guys.
Oh, well,
let there be cake.
Well, cake. Kim, I didn't realize your birthday was on Monday. Wow, so what are you looking for in the next couple of weeks other than birthday cake?
I want to see what Congress is going to do. We saw the terrible economic numbers today for the second quarter. We saw the unemployment numbers, and yet the stimulus, the bill, the unemployment stuff ends tomorrow. So is Congress going to act? Can they rise to the occasion that we're facing? And I don't think they are. They're going to take weeks to do it, and more people are just going to be suffering without any help at all.
Ian, what are you expecting?
Well, I'm like Kim. I'm going to watch closely, see what the Congress does. The schools opening thing, I just don't see how that works. I made the proposal
don't say that.
I made the proposal.
The young kids going, no.
Yeah, see, when you have 35-year-old kids, you don't give a shit. But but the proposal I made is that the kids should go back to school without adults. And a friend of mine said, because I think the kids would love it, but a friend of mine dubbed it as Lord of the Flies Elementary. So that's what I'm looking forward to.
Oh my God, I pity the rest of the kids in my daughter's there without adult supervision. Jen, what are you expecting next couple of weeks? What are you looking at?
Watching out for what the federal government does in terms of supporting people who've lost work and any other changes that are going to hopefully make a positive impact on all the folks that are suffering right now. I think that's a big thing. And then, what's going to happen with schools in this fall? I'm worried about my team and their ability to actually be sane, and you multiply that across the whole country, and that's a big challenge. So those are the two things that are most top of mind for me.
Well, I'll say, but I'm looking forward. We just had we had Bill Barr, basically busted in a bunch of sort of lies, let's face it, by the Congress. And then we had the head of the four big tech companies all be busted in a series of semi-lies as well. I'm looking forward to Katie Porter from Orange County having the congressional hearing of all these companies who apply for PPP and have been and figuring out what happened to the rest of that 500 billion that Mnuchin wouldn't tell us about. And I think, unfortunately, we'll see that healthcare is going to be in a big part of that, especially given that a couple of weeks back HCA had that huge quarter based primarily on that. And I see that the AHA, American Hospital Association, has appealed that the 100 billion in early Medicare loans that were given out by CMS should be forgiven. So I see a lot more boondoggling going on, and it's hard to imagine how we can reconcile that with the fact that we can't extend $600 a week to people who are unemployed, and as Ian says, are going to continue to be so for some time.
Get your wire transfers to Brazil made, people.
Let's not discuss my wires to Brazil anymore, but they were all legitimate. I can explain to this later. Matthew Holt's money laundering service is closed for business at the moment. All right. And with that, I want to really thank my guests. It's been a really great episode of THCB Gang. I want to thank Rajesh Aggarwal from Jefferson, bariatric surgeon and head of innovation there. Kim Bellard from Cincinnati, former editor of Tincture and now regular contributor to THCB. Jess DeMassa, my co-host on Health in 2.0 and the host of WTF Health. And a bunch of great interviews there. And of course, Ian Morrison, healthcare futurist, former president of IFTF at SecCurve on Twitter. And I want to really put a great thank you to my guest, Jen Benz. Delighted to finally get you on the show, Jen. Communications lead now at Segal Benz, and someone who knows a lot about what's going on in that mucky world of employers, including whether they should be in healthcare at all and whether she should be putting herself out of a job and retiring, which may be where she's going with this whole thing. That's the THCB Gang for today, the 30th of July. We'll be back here same time, same place next week on Thursday, 1 o'clock Pacific, 4 o'clock Eastern, with another version of the gang talking about whatever craziness happens in the next week.